Hi, this is Dr Bhandarkar. I'm an orthopedic spine surgeon. Today we're going to discuss about how do I approach patients with spine-related pain. The most important thing I do for my patient is to give them a diagnosis. The essential question I'm trying to answer is, where is this pain coming from? As a first step, I go ahead and do a comprehensive evaluation of the patient by going ahead and doing a history, a detailed physical examination. Following that, I may go ahead and investigate the patient with imaging modalities like X-rays and MRI. After this is done, I go ahead and put everything together and formulate a working diagnosis and also shortlist some differential diagnosis. With this diagnosis in my mind, I draw some conclusions possible where is the pain coming from. And after this comes the next step, which is very important and kind of differentiates my approach from other approaches. I go ahead and confirm those speculations by doing injections. I always give this example to my patients. Say your body is made up of multiple pain generators. A pain may be coming from the disc or from the nerve root or maybe from joints in the back. And all these multiple pain generators, I call them as volcanoes, light up when you do the MRI. They may be active pain generators like active volcanoes, or they may be dormant pain generators. Everything is shown on an MRI. My job is to find out which is the present active pain generator. The best way to find out is by doing an injection. So as a next step, I go ahead and do a local anesthetic injection into that pain generator, which I came to a conclusion after studying all the MRI, physical examination, the history. And then I evaluate the pain response to that injection. If the pain response is pretty good, then I come to a conclusion that this is the pain generator that has been bothering you. So I end up treating the patient, not the MRI. And with this approach, I'm able to focus my invasiveness into a smaller area. The injections do not burn any bridges, and it also gives kind of a trial of a procedure to the patient so that the patient is able to decide and also gain confidence if that particular procedure is going to help him or not. I also use my knowledge of natural history to determine what modalities I'm going to use on this patient. Is this patient going to be treated with just conservative management, or is this patient going to need some surgical management? Is sometimes decided by the natural history of the disease. Natural history means what happens to the patient if we just do nothing to the patient and wait for some period of time. So if the disorder has a very good natural history, I tend to treat those patients with conservative means, which means no surgery, just with some physical therapy and other modalities. Along with diagnosis, with this imaging modalities and with these injections, I am able to quantify the disease problem. I'm able to know the extent of the disease. I'm able to know the grade of the disease, and I'm able to also understand how much of a functional limitation is causing to the patient. After understanding all this, I'm able to formulate a plan or use a modality catered to the patient's individual need and the pathology the patient has. This way, I'm doing minimal surgery, and if I tend to do surgery, I will be doing a minimally invasive surgery. By this approach, I think I'm able to do the best justice to the patient's pathology. Thank you very much.